Renal cell carcinoma is a model disease for using better understanding of the underlying biology to treat patients with targeted therapies. This dates back to our early understanding of the fact that functional loss of the von Hippel-Lindau protein, VHL, leads to upregulation of various downstream effectors, most importantly, the vascular endothelial growth factor, which drives tumor angiogenesis. And over the last 10 years, we've seen a revolution in this disease, development of serial agents that make use of this knowledge and target tumor neovasculature effectively in our patients. As a next step, we now learn that acquired resistance to these medications can also be understood by investigating the underlying biology. For instance, we know that certain kinases on tumor cells can be upregulated in patients after some time of them being treated on angiogenesis drugs. Some of the newer agents we have on the market now already take that into account and were developed specifically with that knowledge in mind, targeting these other kinase proteins that can be active in TKI-resistant cells.
The treatment of kidney cancer has evolved over the past 15 years. I call it a dark age when we were in the cytokine era, and that was before 2005. And the reason we were in the dark age was not because cytokine was a bad drug, it's just because kidney cancer is refractory to conventional chemotherapy and the radiation therapy. So cytokine era gave us two drugs, interferon and IL-2, and give patient 100% toxicity, but the response rate is low, 5 to 10%. So that's why I call it dark age. We treat everybody exactly with the same toxicity, some benefit. Then we went into an era, I call it modern age. That's from 2005 to 2014. Within that era, within that time frame of 10 years, we have 7 new drugs approved for metastatic kidney cancer patients. They include 2 different mechanisms. One is VEGF inhibitors, one is mTOR inhibitor. And VEGF inhibitor has 5 drugs: Avastin, pazopanib, sunitinib, sorafenib, and axitinib. The mTOR inhibitors are 2 drugs, everolimus and temsirolimus. These 2 drugs actually transform the landscape of how we treat kidney cancer. We start with, at the cytokine era, I call it dark age because median survival for metastatic kidney cancer patient was 15 months. In the modern era, we actually was able to double the survival to 30 months. So I think that is very, very interesting, and we became, I feel like more like human, really treating my patient. I can give them hope. So now we are actually getting into an era I call it golden age, because from 2015, later half of 2015 and early half of 2016, we have 3 drugs approved. And these 3 drugs represent 3 additional mechanisms. One is cabozantinib, one is lenvatinib, one is nivolumab. And with these drugs available, and I think there will be additional drugs coming up on the market, maybe like ipilimumab, things like that, I think we are going, I call it golden age, because I think our goal should be aiming to double the survival again to 60 months. And that's why I think the landscape has changed so much.
Over the years, our understanding of the biology of kidney cancer variants has greatly improved. And we now know that kidney cancer as an entity is really made up of many different variants. The understanding of that used to be very rudimentary. One of the most commonly cited classifications used, the Heidelberg Classification that was published in the 1990s, really just subgroup patient based on microscopic morphology and immunohistochemistry. And at the time already defined the variants that we all know well now: clear cell kidney cancer, papillary kidney cancers, chromophobe kidney cancers, and so forth. But since then, with the development of newer technologies, our understanding of the underlying biology for all of these variants has greatly improved. The best example for that is probably the Cancer Genome Atlas Project, the TCGA, which now has done separate explorations of understanding the biologies for the main kidney cancer entities. The original TCGA for clear cell kidney cancer was published several years ago in Nature. Subsequent to that, we had the papillary kidney cancer TCGA in the New England Journal of Medicine. We've had the chromophobe kidney cancer TCGA, and those efforts, which were multi-center efforts throughout the US, really helped understand the molecular underpinnings of all of these variants and helps us now to learn that within these common variants there are subgroups that behave differently and probably should be treated differently in the future.